Hello, everyone. Just give us 1 minute, please, and we'll get started. Hello, everyone, and welcome. I'm Jenny Carolina Bell, Jefferson's Assistant Vice President of Alumni Relations, and I'm delighted to welcome you to today's webinar, Impact Through Innovation, a Department of Medicine update. Thank you for taking time to join us. We're thrilled to have such a broad and engaged audience with us today, including alumni, faculty, colleagues, and benefactors of Jefferson. That's our goal today. The Office of Institutional Advancement and Alumni Relations wants to keep our alumni and supporters informed. We also often highlight the impact of philanthropy on our programs and mission, which is to improve lives. We have a fascinating hour ahead hosted by Dr. Greg Kane, Jane and Leonard Korman Professor of Pulmonary Medicine and Chair of the Department of Medicine. You can see from our agenda here that we will highlight 4 innovative programs that are driving meaningful outcomes for our patients. Before we begin, just a few quick housekeeping notes. Today's webinar is being recorded. The chat is disabled. You're welcome to submit questions at any time using the Q&A feature. They will not be visible to the audience. We'll reserve time for Q&A at the end of the presentations. Lastly, please stay in touch. We have our general alumni email here, and I'm also joined by my development colleagues, Kelly, Katie, and Ned. They're all happy to connect after today's program if you have any outstanding questions or interest in learning more about what you hear today. It's now my pleasure to introduce our host, Dr. Gregory Kane. Dr. Gregory Kane is a nationally recognized leader in pulmonary medicine, critical care, and medical education. He has served as chair of Jefferson's Department of Medicine since 2011, leading the university's largest academic department. A proud Jefferson alumnus, Dr. Kane earned his medical degree from Sidney Kimmel Medical College and completed his fellowship at Thomas Jefferson University Hospital. He has dedicated his career to advancing internal and pulmonary medicine, mentoring physicians, and strengthening academic medicine on a national level. Beyond his leadership roles, Dr. Kane is deeply committed to Jefferson's mission and community, and we're grateful for his continued vision and guidance. Dr. Kane, thank you for hosting today's program. I'll now turn it over to you to begin our webinar.
Thank you so much, Jenny. Thank you so much, Jenny. It's great to be here. I'm going to pause for a moment, and Jenny, just let me know if the audio and visual is working okay.
I do see that you're frozen.
I'm going to go on and off. Sometimes when I turn it on and off, that makes it work better. Is that okay, Jenny?
That's better. Yes, it is.
All right. Well, first, Jenny, I'd like to thank you for putting this together and giving the Department of Medicine a chance to share some of the wonderful developments that have happened here over the last several years. And I think the 2 words that are part of the title of this presentation, impact and innovation, really describes what we're about in the Department of Medicine. And today we're going to learn a little bit about that through the prism of what we've just completed in our lung transplantation program, which is just about 1.5 years old now, what we are doing in hospital medicine to offer new hope to patients who are facing addiction, what we are doing in benign hematology in the field of sickle cell, and then in closing, what we're doing to bring greater service to our patients in kidney transplantation through a program now that's more than 40 years old, but continues to innovate. When we think of those 2 words, we essentially think of the community that we serve and bringing new and creative ideas to improve the services that we offer our patients. And I'm so thrilled to bring each of these together today so that you can learn a little bit more about what we're doing. Jenny, I'm going to start by asking Dr. Neeraj Sinha to pull up his slides. As I introduce Dr. Sinha, he is Professor of Medicine and Medical Director of our Lung Transplantation Program. Dr. Sinha has had perhaps one of the most difficult jobs in all of medicine, which is to launch a new transplantation program. He started this in the beginning of 2024, and we're thrilled by the progress that he's made, and I'm just delighted that I'll have a chance to share that with you. Dr. Sinha, I'm going to turn over the presentation to you.
Thank you, Dr. Kane. Thank you for having me over here, and thank you for the nice introduction. I'm Neeraj Sinha. I serve as the medical director of the lung transplantation program at Jefferson Health, and I'm going to present on the progress that we have made in lung transplant medicine at our enterprise. So the planning for the lung transplant program started much before I joined, even before the surgical director, Keshava Rajagopal, joined. He comes with training from Duke and background experience as a lung transplant surgeon at the University of Maryland and UT Houston. And I trained at Baylor as a lung transplant fellow, and then became a part of the faculty at Houston Methodist and University of Miami. I served as the medical director of the lung transplant program at University of Miami for 6 years before I came here to start the lung transplant program, to be a part of this new lung transplant program at Jefferson Health. We got our OPTN, which is the key regulatory body for lung transplantation in the US, in July of 2024. And then within a couple of weeks, we got our first referral, and then we performed our first lung transplant in December of 2024. Why have a lung transplant program? Why have a third lung transplant program in Philadelphia area when Penn and Temple have already existed? And the reason was rather sound. Jefferson Health is a large 32 hospital network with 700 plus care sites. And it used to be 3 hospitals in 2015, so that's rapid and large growth. Jane and Leonard Common Respiratory Institute, which is a collaboration between Jefferson and National Jewish Health. It anchors system-wide advanced pulmonary programs in our enterprise, and our pulmonology and lung surgery divisions are ranked in top 50 as per US News, and our Moss and McGee rehabilitation is ranked number 8 nationally, and our respiratory care and nursing care are award-winning care. So the ingredients for a successful lung transplant program were there. The patient base was there. So that's how the lung transplant program got started. Since the onset of lung transplant program, over last 18 months, we have had 219 referrals. We performed 27 evaluations, and we added 11 patients for lung waitlist and 1 for heart lung, and 11 lung transplants have been done. 5 of them were double lung, 5 of them are single lung, and 1 patient was combined heart lung transplant. Many of them were ECMO as a bridge, which are supposed to be amongst the highest risk groups. So right from the start, we have been performing at, or we have been accepting higher risk. The donor offer acceptance rate has been 8%, which is quite good. And we have submitted for CMS approval after performing the required minimum number of transplants for the CMS approval. This is why we do the lung transplant. The restrictive lung diseases like pulmonary fibrosis, obstructive lung diseases like COPD, they form the majority of the candidates who underwent the lung transplant. One of the patients had heart failure and secondary pulmonary hypertension and underwent heart-lung transplant. The referrals come from all over the enterprise. Central City, Northeast, Lehigh Valley, and South Jersey. 64% were Caucasians, 18% Asians, 9% African Americans, 9% Hispanics, and 64% of the recipients had female birth sex. All the patients are surviving and following the expected trajectory after the transplant. Those who have already been discharged have 70% of them had the Karnofsky scores of 100, which is the highest score, and then 30% 90, and the heart-lung transplant patient is still in the hospital recuperating as expected. So it's a new program. The challenges that we have faced are that we do have two other established lung health as well as lung transplant programs, Penn and Temple, and we are working on improving the volume of referrals even further, and also having a better risk portfolio. Small volume program means that the monthly case volume can fluctuate. Some months number of referrals could be a lot higher than the others. Number of evaluations could be a lot higher than the others, and then transplant follow after that, and same kind of fluctuations can happen. And when those fluctuations happen, they could be a strain on the resources in the hospital, and those surges need to be managed with appropriate planning, so that we don't have delays in our pathways when such surges happen. The opportunities are that, as we have the large enterprise, and we have several pulmonary practices throughout the enterprise from Lehigh to South Jersey, and we want to continue to integrate and expand on those practices and have a seamless access from the regional clinics to the central city transplant services. As our volume grows, we want to establish biobanks of blood, of the bronchoalveolar lavage, which is relatively an easier tissue to get, and tissue specimens, including the native lungs, which come out after the transplant, for research, including biomarker discovery. Being a new program, that brings us the advantage of adopting the latest and greatest technologies to enhance patient experience. So we are working on adopting home-based telemonitoring. Those are some of the items on our agenda. That brings to the end of my presentation.
Dr. Sinha, thank you so much.
You're welcome. Thank you.
We're going to continue on with our second presentation and save questions for the end. But congratulations again, Niraj, on the incredible work there. Our next presenter will be Dr. Rebecca Jaffe, and she'll be bringing up slides as I introduce her. Dr. Jaffe is professor of medicine. She is the chief of our hospital medicine division, which takes responsibility for primary care of the majority of patients that are hospitalized at Thomas Jefferson University Hospital, not only in the Department of Medicine, but frankly, throughout the entire hospital. Her group brings unique expertise in dealing with common problems that bring patients to the hospital, and has worked hard to develop an action plan for one group of patients that has particularly been in need of addressing their healthcare crises, which are patients who have faced addiction. We're really proud and excited by what this program has offered some of our most needy patients, and I'm delighted to introduce Dr. Jaffe to tell you a little bit more about this. Dr. Jaffe?
Thanks, Dr. Kane. I am just going to do a quick check on whether this is sharing correctly.
Perfect.
Great. So as Dr. Kane mentioned, I'm Rebecca Jaffe. I'm the Division Director of Hospital Medicine and also the co-founder and co-director of our Jefferson Addiction Multidisciplinary Services. I want to acknowledge as I start this talk the role of the Scheller Family Foundation in supporting some of our pilot programs, specifically the Bridge service, which is our ambulatory counterpart for the inpatient work that my division is very invested in. So I would wager that all of you are aware that the opioid epidemic has hit Philadelphia particularly hard. Fewer of you may be aware that Philadelphia is considered really the epicenter of the epidemic nationally, and that we encounter clinical syndromes here in Philadelphia before they're seen anywhere else in the nation pertaining to a highly adulterated drug supply. This article I'm showing here from the New York Times came out in 2023, publicizing the struggle we've been facing with a novel set of veterinary sedatives in the supply, causing severe wounds and acute heart failure. And you can see that while this became a national issue in 2023, this data from the city of Philadelphia shows that the increase in admissions of patients to the hospital with severe skin and soft tissue injuries quadrupled between 2019 and 2021. And so we were facing this on our services before there was real awareness of the problem or protocols to treat these issues. Specifically, the patient featured here in this article, Brooke Peter, is a patient of one of our Jefferson practices. So when this article came out, it really hit very close to home. Beginning in 2021, the Department of Medicine in my division, specifically hospital medicine, has been leading a cross-departmental collaborative to build an ecosystem for effective and integrated care for people who use drugs. Our vision is to build the kind of red carpet wraparound care that we see in diseases like cancer or organ transplant, but focused on people dealing with addiction and the medical complications thereof. We're working across 4 core domains in the design of this ecosystem. You can see here where we're focusing on community partnerships, the entry into the acute care domain, which has really been flourishing with a collaboration with the emergency department. Inpatient care, where our areas are focused through the development of a really leading consult service model, and post-acute and ambulatory care, for which we're partnering closely with psychiatry and the Department of Family and Community Medicine. I'm going to show you 2 pictures to try and capture some of the areas that are central to our approach. Our impact really intends to be understood by considering the patient experience of those people seeking care for their addiction. This image is one of many on the internet showing how the public often envisions people who use drugs in the current era. The internet, like I said, is flooded with these images that are highly dehumanizing. We aim to treat the patients coming to us as humans who are experts in their own experience and integrate trauma-informed care, respect, empathy, and real human connection in the work we're doing. We believe that the care we're providing in this new ecosystem of care can help bring about the same kind of transformation that the world has seen in the treatment of HIV, where reducing stigma and systematically eliminating real and perceived barriers to care has transformed both the disease and the experience of people who seek care for HIV, allowing them not only to survive, but to thrive. This picture from the upper whatever side that is, left-hand side, is not from COVID. That is from 1983 at the beginning of the HIV epidemic. I think I can best illustrate the way that our model works by telling a patient story. So I'll tell this adapted story of a patient we'll call Sarah. Sarah is a patient with a serious heart valve infection caused by bacteria introduced through injection drug use. She initially was in the hospital receiving antibiotics, but left with still needing 4 weeks of IV treatment against medical advice, or what we call as a patient-directed discharge. She returns about a week later with ongoing fevers, knowing that she needs treatment, but really terrified of experiencing withdrawal and re-entering the acute care system. With JAMS, or the Jefferson Addiction Multidisciplinary Service, in place, her experience unfolds completely differently. In the emergency department, the clinicians can act immediately by using an evidence-based order set to control Sarah's withdrawal symptoms. Before she's even readmitted, a certified recovery specialist or peer with lived experience of drug use is able to review her prior care plan and meet with her. Sarah explains to the CRS that while her medications were previously controlling her withdrawal, the isolation that she experienced in the hospital was unbearable. And she overheard a discussion in the hallway about a possible valve surgery, which triggered really overwhelming anxiety, leading her to leave the hospital. The CRS promptly brings this insight to the JAMS team, who can guide the emergency department and admitting teams, both of whom are new to Sarah's care and have no pre-existing relationship with her, to restart prior medications, which were working well. Throughout her stay, Sarah then receives daily in-reach from the JAMS navigation and support team, which consists of peers and social workers, reducing her isolation and anxiety and supporting her as she goes through the difficult decisions that need to be made. On hospital day 1, a multidisciplinary meeting with infectious disease, cardiology, cardiac surgery, and JAMS clarifies Sarah's treatment plan. It's determined that she actually does not need valve surgery now, although it may be needed in the future when her recovery is more stable. This plan is explained to Sarah with consistent messaging across teams due to the coordination that JAMS can provide. The CRS also identifies unstable housing and lack of a government-issued ID as major barriers to recovery. The navigation team can work across community partners to address these needs and develop a safe district plan. Sarah gets referred to a specialized post-acute program run by DBH IDS, which is a city agency, for patients with addiction and complex medical comorbidities, where she can complete both her antibiotics and receive recovery support. Before discharge, she receives an injection of long-acting buprenorphine, which is one of the most effective tools emerging to reduce opioid use and overdose risk in the modern era. Sarah then plans to follow up at the JAMS Bridge Clinic after completing antibiotics. Her case is proactively followed after discharge with outreach from our Bridge team until she's seen in clinic for integrated primary care and ongoing treatment for her opioid use disorder. Through JAMS, we're able to resume care seamlessly for Sarah, identify the drivers for interruption of her prior care, preventing her from leaving early, and helping her move closer to recovery. Even with this vision as the North Star, our strategy and tactics have to be adaptable with the current realities within the city. So back to the New York Times for a minute. This is an article that just came out about our newest challenge. As a result of scheduling xylazine, which is the drug I mentioned earlier, in May of 2024, we've seen, thankfully, a reduction in admissions for severe wounds. However, this has resulted in an explosive increase in the detection of a new substance called medetomidine in the drug supply. Medetomidine is similar pharmacologically to xylazine. It binds to the same receptors, but it's about 50 to 100 times stronger. And the withdrawal syndrome for medetomidine is literally a disease we have never seen before and was not known anywhere else in the country when it hit our hospitals, which was in the spring of 2024. You can see in this graph the really exponential increase in admissions to emergency departments purely for severe withdrawal with no other medical driver for their need for care. And many of these patients were ending up in the ICUs. Luckily, the adaptability and working with complex systems that's really woven into the fabric of JAMS allowed us to respond to this. So for anyone who remembers taking ecology, you can sort of think of JAMS as a pioneer species. It's the first species that starts to populate a barren environment and make it hospitable to other life forms. And then the interactions across that larger community allow a mature ecosystem to emerge, supporting numerous complex networks. And this is really how we focused on using JAMS as a catalyst in the care, for people who use drugs. So for the medetomidine threat, this dynamic allows us to rapidly identify a change in patient presentation, update our order sets, disseminate these protocols widely across Jefferson Health, promote cross-institutional sharing with other academic medical centers across the city, resulting in publications alerting the nation to this emerging threat, and then deploy our team members in novel roles to make sure we could meet new patient needs. This adaptable foundation serves the community beyond just medetomidine. You can see here the myriad of partnerships that are possible because of the JAMS and Bridge infrastructure, and how we've been able to capitalize on each of these sort of purple buttons here in order to achieve the outcomes listed in blue, including recovery, retention, reduced mortality, reduced stigma, high value care and utilization, reduced recidivism and staff well-being. All of this catalyzed through being able to use JAMS to take advantage of payment innovation and reform, city, state, and federal programs, philanthropy grants, and our educational infrastructure at Jefferson. So I'll leave you with this final graphic that illustrates the many initiatives associated with JAMS. I'm sure you'll be able to get these slides afterwards and dig into the details, but in coming years, we aim to use this infrastructure to expand its clinical practice model across Jefferson Health to foster a rich continued rich community alliances to implement a mature and professional and cross-departmental model, which really capitalizes on the rich experience and passions across Jefferson's whole community, and educate, engage, and support the future generations of healthcare professionals in the care of people who use drugs, no matter what their ultimate areas of practice end up being. And I'll leave you just with a picture of our team, which is growing and changing every day, but just immense gratitude to the JAMS team overall for all the work that they've put into this. Thank you.
Dr. Jaffe, thank you so much for bringing us an overview of this incredible ecosystem. And I know it not only brings benefit to the patients that are served, but also helps improve the well-being of caregivers by offering real solutions to patients that are facing withdrawal in the hospital. Next, I'm delighted to introduce Dr. Sophie Lanzkron. Dr. Lanzkron is our newest division director in the Department of Medicine. She runs classical hematology. She is also the Cardiza Professor of Medicine and has a special interest in sickle cell disease. As many of you know, sickle cell confronts a large portion of our population here in Philadelphia, and Dr. Lanzkron is bringing very new and exciting therapies to bear for these patients, and we thought that would be the perfect opportunity for her to share this update. Dr. Lanzkron?
Thank you, Dr. Kane. Assume you all can hear me?
Perfect.
Great. So I usually start all of my talks now when I talk about sickle cell disease with this quote that's from the New England Journal of Medicine from our colleagues that talks about there being no other population of patients whose healthcare and outcomes are more affected by racism than those with sickle cell disease. And there's lots of evidence related to NIH funding and foundational funding, both for research and patients, that really confirms that this is really true. So as many of you know, sickle cell anemia is a genetic disease affecting approximately 100,000 Americans. It still decreases life expectancy by 25 to 30 years compared to the general population. The origin we used to think was 3 or 4 times over the last 3,000 years, but there was an article, again in the New York Times, that talked about a study that demonstrated that it probably originated from one person 7,000 years ago, which is really fascinating when you think about it. Having sickle cell trait means you can still get malaria, but you're far less likely to die of malaria, and so provides this survival advantage. And so when you think about this one person being born and the number of lives that were saved because their progeny had sickle cell trait and didn't die of malaria, it's really an incredible number of people that this gene mutation has probably saved. But if you get 2 of these genes, things are not so good, and it leads to a chronic multi-system disease that really affects every organ in the body: the brain, heart, lungs, skin, really every organ, requiring a true multidisciplinary team to take care of this population. And it's been noted that there are a number of system-level barriers to the care of people with sickle cell disease. Some of those are economic. Social determinants of health are a key feature for our patients. Only about 40% of them are employed. We have a lack of disease-modifying therapies. So excluding gene therapy, we had 4 approved medications. We're now down to like 2.5 approved medications. So we've lost more medications than we've had seen of new medications being approved by the FDA. Real lack of comprehensive disease centers to take care of these patients that provide comprehensive wraparound care. And part of that problem is related to not enough clinicians understanding or learning or wanting to take care of people with sickle cell disease, especially adults. And so part of my research interests and my career has been about overcoming these barriers. In Philadelphia, there are about 1,500, we estimate, because there's no surveillance program in the state of Pennsylvania, but we estimate that there are about 1,500 adults living with sickle cell disease. And CHOP has one of the best pediatric programs in the country for this population. And for the last several years had had nowhere to transition their young adults. So I came in June of 2024, and at that time, between CHOP and St. Christopher's, there were over 100 young adults that had not yet transitioned their care to adult care, but needed to. Penn was not accepting new patients. They had just lost their sickle cell lead, who was a mentee of mine who moved to Canada. Here at Jefferson, when I came, they were very short on faculty, and both Dr. Risk and Dr. Rhodes, Dr. McKenzie did an amazing job taking care of every patient with benign hematologic issues, and so there was no opportunity to see new patients. And in fact, only one adult had undergone a curative stem cell transplant in the entire city of Philadelphia. That was at Penn in 2010. Apparently it didn't go well, and there had not been another curative treatment for an adult with sickle cell disease since that time. And that was despite the fact that there were numerous publications, some coming from my old place at Hopkins and others from the NIH, demonstrating the success and safety of haplotransplants for adults with sickle cell disease. So when you think about what the elements of a sickle cell center are, we published this paper a number of years ago looking at all of the key pieces that you need. It's a complex disease. It requires multidisciplinary teams, a good physician lead who's interested in taking care of the population, social worker, community health worker, pain management expertise. And some of these already existed. Many of you, I'm sure, knew Dr. Balas, an amazing leader in sickle cell disease and the care of people with sickle cell disease, who was here for a very long time, very well respected in the sickle cell community. There was primary care. After Dr. Balas left, Dr. Risk picked up the helm of taking care of adults with sickle cell disease and has lots of expertise in directing this program. There was a social worker, there was transfusion support, and there was timely access to specialty care. But there were pieces that needed to be added. And so in the last 18 months, we have opened an infusion clinic. It's my particular area of interest. This is so patients don't have to go to the emergency department when they're having acute episodes of pain. We have hired and supported a psychiatrist who is embedded in our clinic. 30 to 40% of our patient population has depression or anxiety. We have Dr. Attilio is a PharmD who helps with the management in particular of opioids, both in-house and as an outpatient, and also assists with some of our more complex medications. We've hired a patient navigator, and we've trained our nurses to handle sickle cell calls on a regular basis to really support the patient population. So we removed all of the barriers to seeing new patients in the clinic, and we're scheduling about 50 new patients a month. We've also changed the way patients get their pain management. It's now all done within the sickle cell clinic. We do our own pain management. We also have ensured that all patients have patient-specific treatment plans when they come in for acute care, which has been a long time both NHLBI and American Society of Hematology guideline recommendation. And we have a strong focus on getting patients on disease-modifying therapy, including hydroxyurea and chronic transfusion therapy. This is the number of people that we've been seeing in our hematology clinic over the last 18 months or so. And you can see we have lots of visits a month, a lot more than we had before. Some of these are the same people. We know that patients who have lots of acute care utilization need really close follow-up and often need to be seen weekly in the clinic to support them as we make adjustments to their pain medications and their disease-modifying therapy. And so our clinic is robust, and we're seeing lots of people with sickle cell disease now. At Jefferson now, we've performed 2 allogeneic stem cell transplants in 2025, which is really remarkable and wonderful. It is spurring new innovation. So Dr. B in oncology has applied for funding to support looking at novel preparative regimens for allogeneic transplant in this patient population. We have also been approved for Vertex gene therapy, and we hope to be able to treat our first patient with gene therapy in 2026. As far as research goes, we support 4 industry-sponsored trials because we really do need those novel therapies. So some are for pyruvate kinase inducers, some for hemoglobin F inducers. We have received funding, internal funding through a Jefferson and Morse partnership to fund some translational work with one of our faculty who's at the bench, Dr. Srivastava, looking at the role of extracellular vesicles in sickle cell disease. We have an R01 looking at nocturnal hypoxemia. I've been a long-term co-PI of HRSA-funded sickle cell treatment demonstration program grant, which is aimed at improving access to high-quality care. This is supporting a study to examine the role of federal qualified health centers in the care of people with sickle cell disease. And one of the Jefferson medical students, Sam Keys, is helping with that. We're examining the role of ESI in the time to first dose of pain medications. One of our residents, Dr. Solkowski, is helping with this project, looking at the role of our expanding our program here on acute care utilization. And another medical student, Lana King, is working on that. We're looking at the role of the observational unit that's set up in the emergency department on the care of people with sickle cell disease. This is a project Dr. Risk and one of our fellows, Dr. Patel, is looking at. And I lead one of the largest registries for people with sickle cell disease, the Granddad Registry, which is really a wonderful opportunity for people who are looking to do research in sickle cell disease, as it is a robust registry with over 5,000 individuals consented to participate. And we also have a biobank here as well. And the future for our program is to have this robust wraparound comprehensive sickle cell care for the adults living with sickle cell disease in the Philadelphia area, with the goals of improving outcomes and the quality of life, decreasing hospitalizations and acute care visits, which will lead to an overall decrease in the cost of care for this population. We really want our patients to participate in trials to identify new therapies so that we have options to provide to our patients. One big goal is to train the next generation of sickle cell experts. And so we're acting as an observership for both physicians and advanced practice clinicians. I want to build our translational research program in sickle cell disease, which will make us really unique. There are not that many programs across the country that do robust clinical and translational work in this disease, and will lead multi-center studies, including the Granddad Registry, as well as studies looking at ketamine for the treatment of acute pain, and hopefully we'll get funded to look at buprenorphine for the use of chronic pain. Thanks.
Dr. Lanzkron, thanks for an amazing presentation. And it's hard to imagine that you've just been here for a year and a half and all of this has taken place. It's really exciting. I'm going to turn our attention to our final presenter, and that is Dr. Pooja Singh, who is the Beatrice Nicoletti Professor of Medicine and Division Chief of Nephrology. Pooja has been now at Jefferson for nearly 25 years. And she's bringing incredible energy to our transplant program in nephrology, which serves a large population in Philadelphia with kidney failure. And one of the things that has really interested me in this space is the number of innovations that we have to offer patients. And I'm excited to give Dr. Singh an opportunity to update you on this. Dr. Singh, I'll let you load your slides and I'll turn it over to you now.
Thank you so much, Dr. Kane. I'm very excited to be here to give you a presentation on nephrology and kidney transplant updates. Before I get started, I want to draw your attention to these three lovely ladies on the screen. The one that you see on the extreme left in green is Ashley, and Ashley is the operations manager for the transplant program. The middle is Debbie, Ashley's mom, who's a transplant recipient. And on the right, you see Colleen, who works for the Division of Nephrology and donated a kidney 20 years ago to her sister in the middle. What connects these three women together? They all work for Jefferson now, but more importantly, when Debbie had her first transplant at another organization in the city, they did not agree to do her transplant again for the second time around, and she came to us and we were able to make it happen. So very proud of this team. Can we go to the next, please? I want to take this opportunity to tell you a little bit about our programs and just some startling facts for you when we get started. There are over 500,000 people on dialysis in this country. Every year we have over 100K who start dialysis new. We do 28,000 kidney transplants yearly, but there are 90,000 patients who are waiting to get a kidney transplant. The transplant list keeps growing, but we are not able to keep up with the number of transplants. Every day, there are 13 patients who die waiting for a kidney transplant, and they don't make it. This is where living donation is really, really important. Next one, please. I just want to take this opportunity to show you our footprint for dialysis. So most of us have driven past a Walmart, a Target, a Whole Foods, Macy's. That in the US, all the retail locations added together is 7,600. Those are the number of dialysis units we have in this country. So I bet some of you have driven past a dialysis unit, and this just goes to show how big this footprint is in terms of dialysis. 1 in 5 Medicare dollars is spent on kidney replacement therapy, although 7% of Medicare budget is just, spent on dialysis. It is about $50 billion yearly just on dialysis therapy, and that's where we have a lot of work to do to get more patients to kidney transplantation. Next slide, please. Before I go on to transplant, I just want to take this opportunity to tell you a little bit of more on our general nephrology footprint. We have a comprehensive hypertension center, which is run by 4 of our esteemed nephrologists. This is where we treat a very difficult cases for hypertension. We work very closely with our cardiology group. In fact, very recently at the bottom, you see a cardiology group. We are also involved with them with the renal or kidney denervation trials, whereby we take some really difficult to control patients with hypertension, and they get referred to a cardiology group to try and denervate the kidney, or sort of take the nerve supply away from the kidney to improve the blood pressure control. Next one, please. And this has really helped us to become a center of excellence, and we continue to have a very strong partnership with them. I want to also tell you about a polycystic kidney disease center of excellence. This is under the leadership of Dr. Zhang. We started this from a grateful benefactor about 6 years ago in our journey. And this is a multidisciplinary effort. And you can see we have radiology, liver surgeons, neurosurgeons, OBGYNs, urologists involved in this multidisciplinary effort. And we're very grateful for the Palapali family who've been able to support us as a center of excellence. And we are one of the 37 or 40 centers in the US that have a polycystic kidney disease center of excellence. Next slide, please. So where do we go from here in general nephrology? Our goal is that in the near future, we will be able to stand up a genetics clinic. And this advantage of having a genetics clinic is not just unique to nephrology, but it extends to gastroenterology, hematology, rheumatology, endocrinology as a multi-D effort within and under the umbrella of Department of Medicine. There are multiple advantages to getting patients and their family members early in their disease progression, especially if there is a genetic predisposition. Early diagnosis means that they could have precision medicine or advanced therapies exposure, as well as slow the progression of kidney disease. We are doing a lot of work in this field, and we are hoping that we would be able to get a genetic counselor, which can support multiple divisions within the Department of Medicine. Next one, please. And while we pivot again, I want to now go back to transplantation. As I started with my first story, we are more than 50 years from the time we did our first transplant. At Jefferson Center City campus, we have done over 3,700 kidney and kidney pancreas transplantation. We want to focus on transplant as the first therapy. So out of that 100,000 patients who are on dialysis, less than 3% of patients end up with a transplant first approach. And that's the most beneficial approach to get transplantation first, not only for longevity of life, better quality of life, but it's also cost savings. We have a program that we do fast track patients if they have potential living donors. And we participate at Jefferson Health with all kidney exchange programs. The kidney exchange program really is that if there is a pair that comes forward to us with a potential donor, but the donor is not compatible with the recipient candidate, we're able to do these swaps that I'm sure you've read about in newspapers and other media, that long chains get created so we can get more patients to kidney transplantation. Next slide, please. And building upon our transplant, I want to share our kidney transplant outcomes. If you see the slide, the bottom graph with the 5 bars, 5 is the best rating you can get for a kidney transplant program in the US. We have consistently been in the 4 and 5 range. This rating is from our Jan 2026 release, and this is one of the best ratings in the country, and we are one of the best in the regions to get your patients to kidney transplantation. We do about 120 kidney transplants, and we have many growth initiatives that we expect we will be ramping up our kidney volume to serve the patient population in the Philadelphia region. Dr. Paula Martinez is a medical director who handles the kidney transplant program, accompanied by a very strong team of transplant coordinators, administrators, and a wonderful transplant surgeon. Next slide. I always say transplant is a team sport, and this team really shows that. This would not be possible without efforts of these individuals that you see on the screen and many of our benefactors who have helped us advance both in nephrology as well as transplantation, that I would like to name a few. The Nicoletti family were instrumental in advancing and setting up the Nicoletti Kidney Transplant Center. They have 2 endowed professorships. I have one of those professorships, and they continue to support us in multiple efforts, including community outreach. To name a few, the Goodman family, the Palopoli family helping us with the PKD efforts. The Pascarella family has been a long-term support for not only nephrology, but kidney transplantation too, including supporting the Berg Directorship, which you see in the top left corner, which is named after Dr. Berg, who was one of our division chiefs directors for the longest time and set the pace for a kidney transplant and general nephrology programs. They've also supported point of care ultrasound in nephrology, which is an advanced technology to help with their trainees, as well as diagnosis at bedside for kidney problems. And the most recent is the small family that you see the picture in the middle, that they just named a room in the Hahnemann Center just last week. So I want to share all of this. And in the bottom, you see the Hahnemann Center, which is a multidisciplinary specialty care pavilion located at 11th and Chestnut, where you would see all the specialties present, including a one-stop shop for our patients to be able to come in and get their care. Next slide, please. I would be remiss if I didn't mention this as a fund that I named and created in honor of my dad, Major General A.K. Singh Fund. I truly believe that money can buy happiness when you spend it in the service of others. So I lost my father during COVID, and I created this fund in his memory. My family's from India, so I traveled quite frequently back and forth, and my dad used to always upgrade me on our long flights. This is a fund honoring his memory for helping transplant recipient patients to be able to travel to Center City location, and it extends not only to kidney transplant, but all transplant patients are able to get rides in order to make that commute very easy for them. I've also named a room in my parents' honor, and I am truly the benefactor of this naming, because when I take care of my patients in these rooms, I just feel my parents are always with me and watching me and helping me do the right thing every day. Next slide, please. And in summary, I just want to stress upon that in nephrology and kidney transplantation, we are cutting edge. We continue to make progress. We want to enhance clinical access. We want to watch out for our learners, our fellows, our residents, and our peer and our providers, that to make sure that they have good work-life integration. We have to work with peoples in all sorts and walks of life, both our patients as well as providers. So managing a multi-generational workforce and their needs is very important to us. And as a division director for nephrology, I'm always trying to connect the dots and find synergy between the Division of Nephrology, the Department of Medicine, and Jefferson Health as an enterprise. And my final quote here is that, which I believe is the mindset shift and the leadership principle. We can complain that rose bushes have thorns, or rejoice because thorn bushes have roses. Thank you so much for the opportunity. The next slide just shows our team. So I would not be able to come here and present to you if it was not for a wonderful team together. And that will be on the next slide. Thank you so much.
Dr. Singh, thank you for that presentation, and thank you for reminding us some of the personal motivations that drive what we do here in the Department of Medicine. I'm going to turn to my colleague, Jenny Carolina Bell, who will help me tend to the chat so that we can begin to ask some of our audience members to submit their questions. And Jenny, I'll turn it over to you.
Thank you, Dr. Kane. And thank you for those wonderful presentations. Yes, we're moving now into the question and answer portion of the program. You can submit your questions in the Q&A feature, not in the chat, please, in the Q&A feature. We'll get as many questions as we can while sticking to time. And if we're unable to address all questions today, we will follow up afterward. I am going to move all of our presenters to the view mode. And so please remember that you are on mute. So you might have to unmute yourself as you're speaking. And our first question that came to us is for Dr. Jaffe. Does JAMS coordinate with other Philadelphia hospitals? And is this a program we're starting to see nationally?
Yeah, great question. So the care of a lot of our patients is really intrinsically fractured, and they go to multiple healthcare institutions to receive care, sometimes within the same week. So it's been a real emphasis for us to establish relationships with others across the city. And then it's really been an emphasis of the cities to foster relationships between healthcare institutions. So it's very bidirectional. Not just driven by us on the JAMS team, but really, others are asking for our participation, and we're asking for what we need. So there are several city-run collaboratives where we get together monthly with Penn, Temple, CHOP, sometimes Cooper, to discuss protocols and how we might work together better in exchange of information for patients who get care at all these locations. We also submit a number of grants every year, and many of them are citywide collaboratives. So really everything we do is sort of acknowledging that the care of our patients is happening in multiple locations and thinking about how we can work more effectively across that. As for are we seeing this nationally? Yes and no. I will say, as I started with the presentation, Philadelphia is both unique and a sort of microcosm of challenges that are being faced everywhere. So there are many networks aiming to share strategies across the nation that are being developed, really like building the plane as we fly it. And we have an emphasis on dissemination as well. So we're always submitting research at various conferences and attending those to try and exchange ideas.
Thank you. Next question is for Dr. Sinha. With greater awareness of the dangers of smoking, are we seeing less Americans needing lung transplants?
Well, over the last 50 years, the number of patients who would come to the lung transplant programs who have been smokers or ex-smokers, they seem to have been coming down. However, the number of patients who need transplant, not necessarily related to smoking-related diseases, has always been very high. And with advances in care and advances in donor recoveries, the number of transplants actually has gone up as that was necessary to meet the needs of those advanced lung disease patients who previously would not be able to survive on the wait list waiting for the lung transplant.
Just checking our questions there. For Dr. Singh, could Dr. Singh expand on the Major Singh program for transplant transportation?
Thank you for that question. So I can mention a couple of things which are out there. Just the transport program that I'm talking about is a fund that our social workers have access to when patients get transplanted. And if they have issues with getting rides for their appointments or blood work, our social workers are able to tap into this fund to help patients get their rides, whether that is an Uber or parking spot, help with parking tickets and whatnot. We're able to support our patients. It is, as I said, under our social workers who are an integral part of a transplant program for all transplant programs, not just kidneys, including lung also, and they're able to support it.
I believe this question is for Dr. Lanzkron. Wonderful presentations today. Regarding treatment advent of gene therapy for sickle cell disease, what's needed from policy and partnership perspectives to make such treatments more accessible?
Oh, excellent question. So there are two FDA-approved gene therapy. One costs $2 million and the other costs about $3 million. So the first hurdle is getting over the payment models. The CMS does have a payment model that Pennsylvania is participating in, which does help offset some of these costs. So part of it is making sure that we are able to support patients financially through this process. It's a huge process. The patients need to have their own stem cells harvested, and at this point, that often, especially for adults, takes 3 or 4 phereses to get enough cells. That is not included in the $2 or $3 million. That's another entire process. The patients then get high-dose chemotherapy and become infertile. So fertility preservation is key. At this point, the companies that are producing gene therapy are supporting fertility preservation, which is the preservation of the ovary or the sperm, but not the process afterwards that actually leads to pregnancy. And so that's a huge hurdle that needs to be overcome. A 30-day hospital stay is an expectation for all patients. So you miss work and being with your family, and all of that requires a lot of support. There is actually in our political climate a lot of support from the head of the FDA and actually from the HHS to support getting people through gene therapy. And so there is support, but there are lots of financial challenges. And also the companies can only manipulate so many cells. And so there is a waiting list for people to undergo gene therapy. And not every patient is eligible for gene therapy. And we don't consider gene therapy curative, only transformative, because we know patients have ongoing reticulocytosis and making new red cells. And so they aren't quite cured like people undergoing an allogeneic transplant. So there are a lot of pieces to these puzzles and a long-term requirement to follow patients up for the long term, at least 15 years after they've received gene therapy. And so we have to be in this for the long haul.
Dr. Lanzkron, is there anything you might add about how we work with the companies that offer these unique services in the gene therapy space?
It's a long process to contract with them, which we are now doing with the Bluebird Bio company. They changed their names, and they're very supportive, but they still have quite a problem with their processing. Some changes made to Vertex, almost you lose 90% of cells that you send to them with each pheresis, which is a huge problem. And so we're all trying to work together to try and improve the process and work with these companies.
Thank you.
Another question from the Q&A. One of the challenges of kidney disease seems to be a shortage of donors compared to the needs. Is there a creative way to encourage more people to make the difficult decision to donate a kidney?
Thank you for that question. The first thing I would like to see is awareness. And with that awareness, comes the realization that who is able or not able to donate. What I mean by that is many times when we are seeing recipient candidates in our offices for kidney transplant evaluation, they have self-ruled out donors, family members, friends, without letting the potential donors undergo a proper vetting process with the transplant center. So I always remind our recipient candidates to ensure that anybody who potentially contacts them for donation, we should not make that decision at the recipient level, but let the transplant center make that decision. We also invest a lot in educational resources, removing myths about donation, myths around donation in underserved communities, kidney disease burden. We do community outreach. We go out to churches to educate everybody about the positives and benefits of living donation. And I want to say that in general, it has shown living donors take such good care of themselves after they've donated that they live longer with a much better, healthier lifestyle and taking good care of themselves and keeping their annual follow-up. So let us do our role here and encourage any potential donors to contact us.
Dr. Singh, can I ask you a follow-up there? You showed a great graphic where family A doesn't have a match between husband and wife, but they can donate to family B so that the son in family B can get a kidney, while the mother from family B donates to family A. How do we get more people to be aware of those creative options that might allow more persons to get a directed donor, even though it's through a more complex sharing process?
Great question, Dr. Kane. The awareness of these creative ways, how we do it. And there's one more layer to this kidney exchange program. One is able to donate as a voucher too, and I want to put a plug in for that. What that means is, let's say I have a grandchild and my grandchild has a kidney disease, it's genetic, they're going to progress in the next 20 years when they're going to need a kidney transplant. But I, as a grandfather, may be too old to donate a kidney by then because I'm going to be in my 80s. So I can actually donate in that pool in the kidney exchange program today and get a voucher for my grandkid later. And that's part and the beauty of participating in such kidney exchange programs too. We start by education in general on our recipient candidates, and that education starts way before these patients end up on dialysis, but in nephrology offices, and by advocacy and raising the awareness in the community about such programs that exist. So just wanted to make sure that everybody knew about that option.
Thank you. And that brings us to time. Before we close out, though, and turn things over to Dr. Kane, I just wanted to leave everyone with the final comment from the question section. My granddaughter is a nurse at Jefferson Center City, and I am proud that she is at Jefferson. All my doctors are Jefferson doctors. Thought that was a nice note to end us on. So Dr. Kane, please close us out.
Thank you, Jenny. And let me just provide 3 quick thank yous. First, Jenny, to your amazing team for helping us organize this complex presentation. Second, to our amazing faculty leaders who are not resting, they're pushing forward and overcoming barriers to bring new and exciting treatments to the patients that we serve. And then lastly, to those who decided to take an hour out of their day to join us and listen in to hear about some of these advances. We're hopeful we may bring you more advances in a future session, but we're really grateful for the time that you spent with us today.
Thank you, everyone.
Thanks, everybody, and take care.